Okay, we're live now. Hello, everyone. Welcome back to another virtual dental shout-in session. Today, we're joined by Dr. Rhiti. Thank you so much for joining us, and the floor is yours.
Thank you, Scott, and thank you, Virtual Dental Shadowers, for having me over. Scott gave the introduction, I am Dr. Rhiti Chatterjee. I am originally from India, and currently I am practicing as a general dentist in Beloit, Wisconsin. So just a few things about me. I belong to a small city in central India called Bhopal. You may be aware of the Bhopal gas tragedy, and it has been kind of notorious because of that. But I went to school there. I earned my undergrad degree, that's the bachelor's, and a master's in the same school. I have a master's in oral medicine and radiology. After that, I practiced as an associate dentist in a multi specialty clinic for 2 years. And in 2018, because of family reasons, I decided to relocate to the United States. My process started from 2018 when I got here. I started taking my national boards and getting through all the prerequisites. And in 2020, I was finally accepted in the University of Colorado in the International Students Program. I graduated in December 2021, so I'm a fairly recent graduate, fresh out of dental school, and I have taken up a position as a general dentist in an office called Gateway Dental Care. It is a Heartland supported office and is a DSO. So I would want to share my story, how my journey started. So back in India, we usually don't really choose dentistry. I wasn't sure if I ever wanted to be a dentist to begin with, but what I was sure of, I wanted to be in healthcare. So we do give our prerequisite exams at the end of high school, and I was assigned the dental college, and I was like, okay, I think I like what I have so far, but I wasn't in love with dentistry right away. It is, I think, after my clinicals in my undergrad started, that's when I actually started falling in love with dentistry. And from there on, I knew I wanted to specialize. And one of my favorite subjects was oral path. Not radiology right away, but it was oral path. I don't know why. I know it's very surprising. Very few people like oral path, but I did. And I was fortunate enough to be able to specialize in oral medicine and radiology in the same school. During my master's program, we are supposed to do a thesis project. So I obtained my research experience during my master's, and we also have didactic training because a lot of specialists do end up going to academia. So I did have teaching experiences, and I was able to travel nationally to present my research work as papers and posters. And then after I graduated, I thought I have been away from clinical practice from way too long. It was a 3-year course, and I wanted to jump right back in. And the best way to do that was to work as an associate in a multi specialty dental clinic. While I was just about getting the hang of being a general practitioner, I decided to get married, and my husband was living in the US. So I had to relocate in 2018. And that's when my whole journey as an international dentist in a foreign land started. I started taking my national boards, and I got through with them. But then I came to a standstill. I was like, what do I do after this? I was very, very unfamiliar with the process. I think the time when I started, we didn't have as many resources as we have nowadays. There are so many platforms who are providing resources to prospective candidates. So I kind of felt lost, that I didn't even know what I was getting into at that point, other than what I needed. So I think the best way to get into the dental ecosystem in the United States is to start volunteering as soon as possible. So I was fortunate that in the same city I lived in, it had a great dental office, and they welcomed me with open arms when I said that I would like to volunteer here and shadow the dentist here. And That gave me a great clinical exposure, even though I wasn't able to practice dentistry as such, hands-on practice dentistry, but I became very familiar with dental scanning, with IV sedation. I actually became a scribe during IV sedation procedures at the office. And I also had a great experience learning how sterilization works. Because I was a radiologist, I think I was able to help with radiographs, take FMXs, and at the same time, I also was offered a volunteering position at the community health systems in the same city. And in Wisconsin, there's a state-funded program which takes hygienists and dental professionals to schools in underserved communities, and they do preliminary checkups and provide sealants to the enrolled students on site. So I was helping with their documentation and data collection and all of that. So that gave me another perspective of public health, I want to say, in Wisconsin, USA. During this time, I received interview invites from University of Colorado during my first cycle. And then you know how Colorado's cycle is a bit off than the rest of it. It's almost ending the usual CAPIT cycle. So I didn't hear back from them for the longest time, so I lost hope. I was like, okay, I'm done with the interview, let me just focus on the next cycle now. So my next cycle had started, and I interviewed at University of Pacific, I interviewed at USC. I got accepted in Pacific, and then I got accepted in Colorado from my previous cycle. So Colorado worked out for me because of several reasons, logistically, and it was a 24-month program. It is the shortest program that I had available. So I decided to go for Colorado, and Colorado is synonymous with the meatball. I had a great experience, I think, not only dental school wise, but also being part of a very, very diverse class. And not just culturally, from the experience point of view, we had like endodontists, we had periodontists, orthodontists, oral surgeons, fresh graduates in our class. So we were working together as a team, and I think I learned a lot from my classmates. Other than that, I also was an active participant in extracurricular activities. I was the community service chair in the Colorado chapter of SMDA, and I was part of the multimedia team for ASDA Colorado. And there were several other roles that I took up. And the reason why I did that was I started to realize that when you graduate as a dentist, you're not only a clinician, but you also have to be a team leader. And I felt that I really lacked in leadership qualities. And I had to put myself out there in those uncomfortable situations and take up these roles because I needed to build myself as a team leader and a team member. So I think I grabbed those opportunities, and I'm using those experiences every day that I'm working now. And so there was a question, I think, which asked that what made me a competitive applicant. I think nothing. I'm same as you. I jumped straight in without having much support. And my strength was I researched a lot. I went, wherever I would interview, I had to go back to the school, find what their mission and vision is, find the students that they like. And what clicked for me was both Colorado and Pacific. They have a very similar requirements from the student. I think they have a very holistic and very humanistic approach in selecting their students. It's not just about whether you're doing great in your bench, whether your SOP is great. They are evaluating you as a human, as a whole human first, whether you fit into their culture or not. And then they know the rest of the part, the clinical part, is something that you can work on. You can be taught. But if you're not a great fit for the school, I don't think so. That's where you actually get, eliminated in the process of selection. But there are two things of which I finally understood from being part of the interviewing committees is, you have to have great letter of recommendations which are genuine. They shouldn't be something that's being copied. So that's why when you're collecting experiences, make sure you're also building bonds so that you can go back to someone and ask them that, can you write me a letter of communication, a letter of recommendation, and they will communicate how they know you, what they know you, what is it about you that they like the most. So you need to build genuine bonds in order to get a great letter of recommendations. So even if you're shadowing somewhere and you're not being able to get a hands-on experience, make sure you're working with the people in those teams. Then I think the second most important part, I feel like some people say it is the first most important part. It is your written material, your application package. It has to be airtight. There should be no mistake in what you're presenting to them. And there should be no falsification of information, because they will get you at that point. Like when you're sitting on the interview, sitting with the interview panel, and you will get asked questions about some experiences that are being brought up in your CVs and your SOPs. So be as genuine as possible. Make sure your SOP reflects your personality. If it's just it has your flavor in it. Because if you're not being able to put your personality across, they don't know the person who's writing that SOP. So I don't think so they'll be able to relate to you, and then maybe think about like, this seems like an interesting person. Even if you are a fresh graduate and you don't have a ton of experience, but if you have a very fun personality, something that a very interesting fact about you, which you've been able to put across, they would want to meet you and learn about you more. So that gets you into the door, at least in the interview, and that's when you have to perform. So make sure you're able to put all of this across in your statement of purposes. It's okay to get help professionally to make sure it's looking trimmed, it's meeting all the requirements, but the story should be yours. Then I think, so I went through I think this is the information I gathered when I was also part of the interview panel at the University of Colorado. And I think that's something that our candidates miss out on, like putting forward their personality. It's okay to like have structured answers, but make it as personal as possible. And while I completed my journey in University of Colorado, I thought that I wanted to do residency at some point of time, but by the time I think I was in my final semester, I knew that I just wanted to stick to general dentistry. And that was because of my patient experiences and how limited uh, access patients do have to dental care. And there are a lot of limitations. It's just not physical barriers, their ability to travel to different places, like because US is such a huge the landmass is so big that people do have to travel like huge distances to be able to get to dental care, medical care, anything. So I feel like I wanted to reach out to the community, make it easier for them to have access to just the basic dental care. And of course, if they need specialist care, nobody's denying them that. We'll definitely refer them out. But if they are trying to reach you with something as simple as dental pain, you can do something about it to begin with. So I think that's why I wanted to stick to general dentistry first. And I wanted to also focus on providing holistic care to the whole person, and not just like, I don't want to just do endo right away. I want to build my patient base, know my patient, know my community more before I know what I want in dentistry. So I started off thinking that I really like aesthetic dentistry, and I do, but I felt like I need to practice restorative dentistry more before I know I'm ready for aesthetic dentistry. So I think to buy myself that time to improve on my restorative care, I wanted to kind of give myself a couple of years in general dentistry to see if I like what I'm doing right now, or it's time for me to kind of change into something more specialized. Then right now I am working on endodontics. I have a lot of cases, so I think I'm falling in love with endodontics right now, but who knows, it may change in the future. But I think as a general dentist, what I see for myself, and I think all other general dentists do, is to continue their education process. Dentistry, when you're in dentistry, your education, or any other field, any profession, your education never stops. And with general dentistry, I think I'm not limiting myself. I just have a lot of subjects to kind of hone my skills on and continue my education on. So that's what it is. Um, in my 1 month of work experience, these are some of the challenges that I came across. And first of all, is I think in my first week, I had 3 patients who tell me, nothing against you, but we don't like going to the dentist. And unfortunately, they came to me when they were in severe pain, when we couldn't do anything but to extract those teeth. So that's one of the biggest challenges that a dentist will face, is to alleviate that anxiety and then get your patient who is terrified of you, get them out of pain. I think that is when you need to have a very humane approach, understand where these patients are coming from, and you have to take the time to build empathy with these patients. There is no shortcut. You maybe only seeing them for 30 minutes that day, but make sure that those 30 minutes count, and you're able to kind of chip away at the wall that they have built up against dental professionals. Then another thing I think is limited care. You will see that a patient is, oh, I just have this tooth which is bothering me, and I only want you to focus on that. But when you take a look, there are so many other things that could be contributing to that one toothache. But I think it's what it is, that you cannot override a patient's autonomy. So you have to kind of just focus on what they want at that point of time. But that kind of was a big challenge for me, that I wanted to go out there and educate the patient, like, oh, this is just not this problem. You have like several other things that are contributing to this. But I think that's where my hands started getting tied. Like, I don't have the time and the resource. The patient doesn't have the resource to focus on anything else other than that particular tooth. So I think that's one of the biggest challenges. And it ties to my third point, is that I want to present a more comprehensive treatment plan, but I think it's not the right time for my patient. They're not in the position to hear about it. So that's where I feel like I have to kind of rein in my enthusiasm to treat that patient as a whole, and kind of like focus on what they need the most at that time. And I think, unfortunately, financial barriers is one of the biggest challenge for our patient to accept the ideal treatment plan. And because of that, we have to kind of come up with several like plan Bs and plan Cs. And it's unfortunate to see that sometimes the patient has to accept a more compromised treatment plan because they don't have the means. Their insurance, they don't have insurance coverage. But there are several other, I want to say, the business assistants in my office. They're very, very well versed about the various plans that they can propose to them, financial plans, which helps the patient somewhat in some means. But I think we need to do better, find a way to kind of alleviate this problem, remove this burden from the patients, which is preventing them from seeking timely dental care. And by the time they come to you, things are beyond repair, and you just have to do what you can do to get them out of pain at that point of time. And so this is one of my cases, and she was the reason why I chose to stick to general dentistry. She was a very sweet lady, but her first complaint was, I'm here for implants. So she's a 65-year-old female, and she was hypertensive, and she was on medication like lisinopril, she was on atorvastatin, and she was also on bupropion for depression. So when she came in, I was like, oh yes, we're going to extract all her teeth, we're going to place implants, I'm going to do complete overdentures for her, implant supported overdentures. It's going to be a great case. But when I started taking these clinical pictures, I want you to see, I will show you, point out several things. First of all, if you see, these are her retained deciduous teeth. These are her retained deciduous canines. She has retained deciduous lower incisors. So, and also when I started my Achilles risk assessment, I came to know that she never brushes. She forgets brushing. She forget about flossing. She was anti-fluoride when she came in. So she didn't want fluorides, anything to do with fluorides. She used to live in a community which didn't receive fluoridated water. She was on bupropion, which has xerostomach effects on your oral cavity. So there was a lot of factors which were working against her. Then we took some radiographs. And as you can see, that she did get dental work done, but there was a lot of patch and fill going on here. And despite all that patch and fill, she was getting lots of secondary caries going on underneath those restorative work that was done on her. And at that point, what do you start thinking? Like, if I do more restorative work on her, do you think it's going to be worth it to give her more crowns? At this point, these teeth are non-restorable. We had to extract them. But what about the remaining teeth that are there? Do you think that it's worth it to do some restorative work there? Her main complaint was, I want implants. So I went back to her and was like, why do you want implants? She's like, I haven't eaten a steak in the longest time. I want to chew food. I want to smile confidently. And this is, she's saying that at when she's 65 years old. So I don't know for how long she has been not being able to eat how she wanted to, not being able to smile for how long, I don't know. So we thought it might have been a straightforward case, but my professor, he was a prosthodontist, Dr. Sutton, he said that let's take some diagnostic casts and mount them, and let's see if we have enough restorative space. And as you can see, we do not have enough restorative space to place implants and then to do some dentures over it. There is no space here, there is no space here. So how do you think, and why do you think that's happening? I will go back to the pictures here and I will see. I'll show you. She has really short clinical crowns here, but she has a lot of bone. So that means that when she was grinding away at her teeth were obviously not the greatest occlusion. So they were undergoing attrition, abtraction, all of that. So to keep her teeth in contact with each other, her alveolar bone was growing out. So she has excess of alveolar bone, but very short clinical height, crown height. So we won't be able to give crowns there without doing crown lengthening and whatnot. So at this point of time, what is the next thing that you can do for, and this is called passive altered eruption of teeth. And that's happening is the alveolar bone is trying to get the teeth that are retreating away to stay in contact, to stay in occlusion with each other. So what the treatment plan that we came up with is looking at these radiographs here. We extracted all her maxillary teeth, but that still wasn't enough to establish enough restorative space for even simple complete dentures. So at that point of time, we had a diagnostic cast, we did alveoplasty, we took away minimum of 3 mm of alveolar bone. And then we waited for when she was healing in her alveoloplasty for some more resorption to take place. And then I think when I graduated, she had just received her she has just undergone her alveoloplasty and had healed. I hadn't seen her what kind of restorative work she underwent after that, but she was planned for a complete maxillary denture, which was only done after we did alveoplasty. And then in the bottom, she would be given, I think, a flexible partial denture with whatever space was available at that time. So I have put in a link here of an article, which was, it is a great article about immediate complete dentures, and it talks about the cast modifications we can do on the diagnostic cast to plan for surgical alveoloplasty. So you're doing the alveoloplasty on the cast first. And if you think you have gained enough space to make those surgical stents, and then when the patient comes in for her surgery for the alveoloplasty, you know beforehand how much bone you need to take away to so that when she heals from her alveoloplasty, you have enough restorative space at that point of time. So I think this was one of the very complex cases I had, but also this case kind of inspired me to, like, being a general dentist, you can do all of this. You don't have to be a specialist, but it's always great to have specialists, friends who you can reach out to, your faculty members who can guide you. And I think this is definitely doable by a general dentist. It's just that if you need help, plan out this treatment plan, do refer with this. You can always go back and have a chat with your prosthodontist friend. And I think this was not my only case which had a collapsed bite. It's called a collapsed video. She had that. And unfortunately, she was not my only case. The very next week, this was a 34-year-old female. And as you see, she has very short clinical crowns and she has a lot of alveolar process. But unfortunately, we love to have great bone, right? But unfortunately, in this case, this much amount of bone was working against her. We lost on so much restorative space. And for this patient, there were several factors which were working against her. She had compromised systemic health. She had grand mal seizures. She was a relapsing alcoholic. She tried in rehab, so all of that, and had gastric bypass surgery. She didn't have great home care, and also she was a soda drinker. So all of this, you can see so much demineralization, carious lesions. And on top of that, because of the demineralization, her teeth were eroding faster than we could even manage to do any restorative work. So these teeth, they look like they have some amount of structure, but they're so hollow inside that even when she was 34 years old, we had to propose a treatment plan that you need complete dentures at this point of time. And not just complete dentures, we need to take away some amount of your alveolar bone for us to be able to give you a good pair of dentures, which will help you in the future. So this was another case, and you will not believe how common collapsed videos are. I think our biggest mistake is not being able to diagnose them, and then giving poor restorative work, or like this. I mean, had I not known this, I would have wanted to come up with a more complex plan of, we can do a root canal on this, we can do a crown on this, let's try to save as much teeth as possible. But we also have to see how much restorative space is available for us to be able to do that, to give her something which will last for at least 5 years. But this situation doesn't help, that she has lost all that space. And so, yeah, these are the two cases which actually made me think that I wanted to do general dentistry, because this was beginning to look, I myself had just, as a student, I had 2 cases myself. I cannot even imagine what my other classmates had. So put together all those cases, do you imagine how common this problem could be? So I wanted to show something really interesting. This is my 3rd case, I think. So this was my thesis patient from India, and my thesis topic was thalassemia, and to record craniomaxillofacial changes in thalassemia patients. So thalassemia is a hemoglobinopathy, as you know, and it affects the bone marrow. It affects the hemoglobin chain, and there are the homozygous state, there are the heterozygous states. My study was mostly concerning the homozygous state, because that's when the genotype completely manifests in its clinical forms. So this patient was a 6-year-old female, and I found her in one of the blood transfusion wards, and I talked to her parents, and asked them, like, does anyone in your family have these, really protruded teeth? And her mom was like very concerned, like, it's just not protruded teeth. She also has a lot of pain, like in her jaws. And I was like, okay, would you be okay if we took an X-ray of her? And lo and behold, if you see her Ceph, you see, this is not only the hair on end appearance that we see, it is even more. So these two corticated bones are her diploid table, and this is the amount of bone marrow that is occupying that space. These are her medullary bones. It has like a more of a ground glass appearance. So this shows that she is her manifestation, her craniofacial manifestations are way more. And in my research, we found that the earlier you start blood transfusions, like she was 6 years old, and that's what the time when she actually started her blood transfusions. The earlier you institute blood transfusion as a therapy in hemoglobinopathies, that's when you can manage craniofacial manifestations like this. So now she's a full-blown ortho case. So at this point of time, the parents are wondering, like, do I want to talk about my child's survival? Because it's a life-threatening disease at the end. Every 6 weeks, she has to come in and get a blood transfusion. Or do I want to give her an improved quality of life? Because obviously her jaw is not in sync with each other. She has class 2 div 1 and whatnot. So it was obviously affecting the child's quality of life. But these are the tough choices which parents of such patients go through. So I really wanted to bring this up because she was one of the most severe cases I came across during my research. And it was like almost like a textbook appearance of what we usually see. Yeah. And I think this was another case that it was a really interesting case here. So this patient, when I saw in his mouth, he had a solid swelling in his lower anterior jaw. And we thought like right away, oh, it could be like fibrous. It's a fibrous growth. It was soft and almost spongy in consistency when we did the clinical exam. Mind you, at this point, we hadn't taken any radiographs. He just came and sat on my dental chair, and that's what we examined. And we found that, and we were like, okay, this could be like a, fibroma, which is like gone out of proportion. You see that there is a traumatic ulcer here. It could be like the ulcer is causing like a traumatic proliferation and whatnot. So we weren't even thinking that it could be like something of like a jaw tumor. We were still thinking that it's originating from maybe the floor of the mouth and whatnot. So we were like, okay, let's do some radiographs. And in this radiograph, this was his occlusal, we see that there is a corticated margin here. So that means this is arising from the bone, despite it feeling that it is not part of the bone in his mouth clinically. So we went and took a pano, and as you can see that it is not only a single, but it is a multilocular radiolucency. Looks very different from what the occlusal is showing us here at this point of time. So we were like, so what do you think are the possible diagnoses when we are talking about like a mandibular anterior radiolucency that is crossing the midline? We're thinking about central giant cell granuloma. We're thinking of more aggressive lesions like ossifying fibroma, some other kind of fibrosis lesion, given that it has like a mixed radiolucent radiopaque appearance here. Right. So we do like an incisional biopsy on him because we don't know what this is at this point of time. Every time we take a new image, it looks different. So his histopath came back, and it turns out to be a variant of ameloblastoma, which is called as desmoplastic ameloblastoma. And that is one of the rare types of ameloblastoma which crosses the midline and is found in the anterior part of the mandible. And we went on to publish this article in BMJ. And it was one of my first cases where I think I went through like 3 different sets of differential diagnosis, and finally histopath kind of confirmed that no, this is ameloblastoma, and then the patient had to undergo jaw resection of that point of time. And I'm not sure if he could afford grafts, but he was an old man and he was from a rural part of India. I know the last time I saw him, he had undergone jaw recession, but this was also one of the variants which kind of recurs aggressively. So I think he was put on a recall. I'm not exactly sure. So these are some of the interesting cases I think I've seen over the 10 years of my career as a dentist so far. And I think these all go back to the time when I was doing my master's, of course, when I was able to see so many interesting cases in my short time there as a master's student. So right now I'm going to just wind up by saying that as a dentist, I know you're striving for perfection. I don't know why, but we get genetically wired that way, that if your work is not perfect, it's not good. It's not like that. You'll never be able to do a perfect restoration clinically, obviously, because a cavity is not going to look like an ideal cavity in a patient's mouth. So I feel like we as dentists are really hard on ourselves. So I think what we lack is to take it easy and focus on our mental health, focus on self-care. And that is something I feel like I was talking to Scott, and it's something I think that is what's missing in dental school, how you need to focus on yourself at the end of the day. Because if you're not the best version of yourself, believe me, you won't be the best clinician out there. Monday to Friday, if you're just continuously working. And I felt that. And I felt that when I started working, I would finish my job on Fridays. And on Saturday, I'm still thinking about the case I did on Tuesday. So it wasn't helping. I wasn't unwinding at all. I'm still thinking about the cases. What went wrong there? What could I have done better? And I'm just starting. And I think I have several more years to go. And I keep doing this. Can you imagine how easily I'm going to burn out? And it's going to happen to a lot of us. So I just want to put it out there that this is a very competitive process to get into dental school, then to come to a foreign land and to try to get into school all over again. And then when you come out and you're like, finally I'm done. I can be a dentist now. But the struggle starts again when you're a dentist again, and then the whole pressure, I have to be the perfect dentist for my patient. I don't care, I'm going to push through. And at the end of the day, it does affect you physically and mentally. So just be mindful that on your weekends, take some time off for yourself. And I also know we are a social media platform here, but let's use these platforms to learn from each other rather than, trying to be competitive. I can do this better. I can do this root canal better. If you see cases which are being put on social media, learn from them as an educational tool. You don't have to compete with them. Of course, I'm not going to do a root canal as good as an endodontist is doing. So it is unfair for me to be able to to be competing with an endodontist to do a root canal of that level. So just be mindful of these things. These are small self-care hacks, if you can say. So yeah, that's what I want to wind up this presentation by saying, just go easy on yourself. It is going to be hard to do that, but always try to check in with your peers. Everyone's in the same boat, going through the same struggles, maybe at different paces at different times in their life, but check in with yourself and your family members and your friends, and take care. Thank you.
And we'll go to the next slide?
Yes.
Let's see. Okay, so now we're gonna go into the Q&A. And thank you so much, that was very informative. And let's see here. Hello, Dr. Rhiti. Do you have any tips for Colorado International Trained Dentist Program interview?
Like I said, I'm going to reiterate that during your interview, just be very confident and personable. I feel like I have had experience of being on the interview board, and what I know is if you have an interesting personality, they will love you and they will want you to make yourself likable. They will want you to see you again, like, okay, maybe she doesn't have that experience, but I can teach her that. But, if you're not likable, then maybe like, even if you have the greatest experience, you could be like a great implantologist or prosthodontist. And if you are not likable, I don't think so they will want to call you back. So just go as easygoing, be the fun self that you are. And I think that helps immensely.
And okay, so you say you have worked as the interviewer, the panel for interview. What was the most memorable interviewee that you have seen?
I think there was this one girl, I do not remember, but we talked about everything other than dentistry. We talked about which movies she liked. We talked about, of course, there were a couple of things that when she was telling her experience as when she wanted to shadow and whatnot. And then somehow our conversations would be like, oh, I got inspired because of I watched this movie. And then our conversations would be about like movies and foods. And those are the things that are memorable. Okay, maybe I don't remember whether she was like given a second interview or the bench exam, but yeah, those were like fun ones. Like, like there was a guy who was like, I race bike or something like that. I spend my evenings like racing around on my bike in Chicago, and like those fun stories. If you can just put in those fun aspects of you, your personality, because most of the other information you have on your CV, you have in your statement of purpose, and they have reviewed all of that. Our follow up questions usually arise when we find something interesting in your CV, and we'll ask you those questions like, oh, you mentioned that you have been like, uh, for example, you were part of an organization. What did you learn from it? How did that help you? Why do you think we should be, considering that experience as being an important experience for you? Something in those lines. So yeah. But again, I say do not falsify any information. That's where you get caught.
And would you say being serious during interview is better, or you can be kind of like funny and just be a little bit less serious? Would you say that's better?
Yeah, that is always better. Like, imagine you and I are having a conversation. 10 minutes of you being serious and me being serious, you'll get bored easily,
Yeah.
right? You want to have like a smile, carry yourself with confidence. If you smile and you have a pleasant personality, even if you're nervous, that's forgiven. Even if you're like stuttering and stammering, that's human. Everyone knows that it's a big day for you. Everyone has been in that position. And I think what Colorado does is like, because we have students on our panels, interview panels, they do as and the students know that they have been in that position not too long ago. So I think it's a very they try to make you as comfortable as possible. So for you, if you are as easygoing as possible during your interview process, it is easier for you to maintain the flow of conversation as well. If you are very serious, then you only are focused on like, I want to answer that question, and I would remember that, oh, what are your strengths? And you are trying to recollect. You've obviously prepared that answer. What is your strength and weakness, right? So you're trying to think too hard, oh, what was my answer that I've learned? And it shows that you've mugged up that answer, you're like trying too hard. And that doesn't usually go in your favor. So just be as easygoing as possible, keep smiling, and I think everyone does a great job overall, I think.
The next question is, I'm confused when schools ask me why am I applying for their program, what kind of factors I have to consider in that case.
So that's where I want to go back to the point where I say you have to research about the mission and vision of the school. What is the school looking for? Talk to their alumni, talk to their current students. I think now with social media, it's such a great tool to be able to connect with current students in the schools that you're applying for. And you can ask them, for example, like I said, like in Colorado, one of the biggest things that the faculty members are looking for is the student teachable? And that's one of like, if you have a great personality and you are teachable, they will give you a chance that you can be taught to do a class 2, a class 3, a denture or whatever. But if you're not teachable, what's the point? They're wasting their time and their resources, and it's an unpleasant situation for everyone, right? So that's for Colorado. That's not for every school. But if you're talking about a school, if you are applying to a school, you have to make sure that you know their mission and vision, what kind of students usually get into the program, and what is it that they're usually looking for. Some schools do prefer research background. Find out whether you have. If that is your dream school, then find ways to do research. If a school is more focused on like clinical experience, sometimes it's hard to get a clinical experience, especially with COVID. It was really hard to do like physically shadow people and get all that DA experience and whatnot. But if they see that you're trying hard, even bench prep courses are now being given some consideration, because schools are thinking, okay, you took that course, that means you're really serious about maintaining your clinical experience, your hand skills. So if you have taken that course, I would suggest like, yeah, put them out there. Like, I've taken that course and I'm working hard to, keep myself, my hand skills on, like keep working on it. That means you're dedicated to dentistry. That's what most schools are looking for.
What are the pros and cons you observed with small class size versus large class size in DDS?
Um, it's not about the class size. I think it's about the patient pool when it comes down to that.
That's
Like,
true.
how extensive is the patient pool? Like, as a big class size, you might still be getting enough patient pool, and in the small class size, maybe if you're not getting enough patient, it doesn't make sense. So I want to say a moderate class size. It's somewhere in between 6 and 80. I think we were 40 of us. So I feel like it's more about whether you function well in a bigger class or a smaller class. Like, what is your outlook? Like, do you think you'll be able to work better with 6 people and you have a great one-on-one connection, or you want to work with 40 people and you can learn from 40 different dentists?
And what do you think about the patient pool in Colorado?
I think we had a great patient pool. Unfortunately for me, I was in school during COVID,
Oh
so
yeah.
our patient pool got cut short. But our patients were waiting to come into school. We just couldn't get them in because of the protocols we had to
Yeah.
follow and stuff. So we do see a lot of medically compromised patients. We have veterans programs. So the VA, we work alongside with the VAs, and we had a lot of veteran patients. So we see patients who have been in combat zones. They have had several procedures, joint replacements. So the whole
Yeah.
medically compromised patient pool. And we do have a strong, because we didn't have a prosthodontic residency, we do most of the pros work. So I think that was one of my strongest points in Colorado. So if you have like a medically complex patient pool, most of them are also older, and we didn't have a pros residency program. So all of that combined kind of helped me get a great pros experience, if it helps.
And I know that educating patients from the rural areas is very challenging. What was the treatment plan for the fourth case and you presented, and how did you convince the patient for the treatment?
So the patient actually, in that case, because it was so evident, the swelling was so evident, it didn't really take too much for us to like convince him that he needed that surgery. He came in mentally prepared, knowing that something was wrong. So, but however, it is a possibility, and I have experienced that when patients go in denial and they refuse uh, the treatment plan. In that case, you have to give them the space, because patient autonomy is one of the biggest ethical situations that you will come across. It is your duty to give them the right treatment plan. It is your duty to educate them. But at the end of the day, whether the patient wants to go through with that treatment or not depends on the patient's autonomy. So you will have to, like I say, if you are able to establish an empathetic, you come across as an empathetic doctor, you're not pushing too hard, however, you have to be honest with them. You have to tell them that if you're not taking care of the situation, these are the consequences. And you can always soften it up by saying that, I don't want to scare you, but this is what probably will happen if you don't take care of it right now. And I feel like when you're being honest with the patient, and if you're able to work at their pace, then most patients do accept the treatment plan.
Can you share some light on the virtual bench exam?
So unfortunately, I was not part of the virtual bench exam, but I can tell you one thing: it does comprise of complex cases. One of them will be I think it's a wax up, which they tell you to evaluate, and you basically have to find the deficiencies in that wax up. What is missing? Like, for example, is there an open contact there, and what is the is there deficient margins there in the wax up? Those kind of things, and then they will ask you to evaluate a class 2 prep or something of that sort, and you have to find kind of again identify what's gone wrong in those class 2 preps, how can you correct it. And the third is a complex case where my first case, you can see that they'll present you with clinical pictures, they will give you a panoramic and all the associated radiographs, and you will basically have to identify anything that you see is not out of the normal. So if there are any deviation from normal anatomic landmarks in the radiographs, you have to mention those. You have to mention all the findings that you're seeing, like they have a lot of restorative work done or something of that sort. And also at the end of the day, come up with a comprehensive treatment plan. So these are the things that usually happen in the virtual bench exam, but every year it has been different. So I cannot say like this is what it's going to be followed this year. Every year, I think they've had 2 so far, and both of the times they have been very different. So I think the best advice is when they do send across that information to the candidates, that you have to be prepared for this. What I have seen candidates do is they're so focused on the first exercise, they do end up taking up a lot of time in the first and the second exercise. By the time they get to the complex treatment plan part of it, they're running short of time, and then there's kind of missing out on findings, treatment options, and all of that. But just practice the timing part of it. I think if you're mindful of the time, that will help.
And what does dental school mean by didactic courses on their curriculum?
That's the classroom courses. So what is being taught in the classrooms is the didactic portion, and the clinical part and the lab work is what's happening on the clinic floor and the labs.
And I think we're running out of time, so I'm just gonna ask one last question.
Sure.
What was something special, like CV or like personality wise, you see from the fresh graduate in your class that you think that the school, that's the reason why school picked them?
I think you answered the question yourself. If it's a fresh graduate, it is understandable that they won't have as strong of a CV. So then it's all about their personality and whether that person came across as being teachable, as a good fit for a class which has like specialists and general practitioners who have been in dentistry for like 10, 20 years. So they are very good at assessing whether this fresh graduate will be able to mingle in that class or not, whether they'll come out as a successful dentist being in that class or not. So it rides a lot on your personality, whether your personality will be able to withstand the stresses of being in a class which has other specialists and general dentists who've had previous years of like decades of practice experience.
Got it. Thank you so much. I think that's all we have for today. And for the viewers, we're gonna put out the quiz onto our link tree, so remember to fill it out before it got expired.